Hello, my name is Jennifer Stransko, and I'm the Physician Engagement Associate for MAVEN Project. Thank you all for joining us today and our friends at Duffy Health Center for hosting today's session, ECG Mini-Series number 2, Ischemia and Other ST and T-Wave Abnormalities with Dr. Charles Schulman. Dr. Schulman was an assistant clinical professor of medicine at Harvard Medical School from 1988 until 2018. He is currently a corresponding member of the faculty of Harvard Medical School and a senior physician at the Beth Israel Deaconess Medical Center in Boston. In addition, he has been practicing non-invasive cardiology since 1970. Dr. Schulman's scientific articles and abstracts have appeared in the New England Journal of Medicine, Circulation, the American Journal of Cardiology, and the British Heart Journal. His research interests include the treatment of hypertension, congestive heart failure, and hyperlipidemia. And Dr. Schulman, you can go ahead whenever you're ready.
Okay, well, thank you very much, Jennifer, and good afternoon, everybody. It's nice to be with you again. So this is the second of 3 ECG talks, and in this talk we're going to focus on the ST segment and T waves of the ECG and abnormalities thereof. Oh, I have to do this. All right, there's my pointer. And okay, so I have no disclosures, nor does anybody else that has any influence on these educational activities. And this is you get a 1 hour of category 1 credit for this session. So as a result of this activity, I hope that the attendees should be able to recognize deviations of the ST segment and T wave of the ECG, to know when ST elevations and T wave changes represent ischemia and when they do not, recognize prolonged QT or interval or QTC, corrected QTC, and its risk, and know the etiologies of ST depression. So here is the standard electrocardiogram, P, QRS. This is where the QRS ends and the ST segment begins, is called the J point. This is the ST segment, and this is the T wave. Okay. The QT interval is from the beginning of the QRS to the end of the T wave. And that corresponds with phase 2 of the action potential of a contractile cell. So ST and T wave changes may involve ST elevation, ST depression, or T wave changes, and this illustrates the standard ST segment at the baseline, ST elevation, ST depression, and these are some of the causes of ST elevation that we will talk about. Likewise, we will talk about these causes of ST depression. And then there are T wave changes that may either, the T waves may either be inverted or peaked. So starting out with ST elevation and the ST elevation of acute myocardial infarction. What you should know is that the initial change on the electrocardiogram is a tall T wave called a hyperacute T wave, and that's because the T wave vector is traveling toward an electrode that serves the area involved, followed by an ST vector in the same direction. So remember that vectors that travel toward the electrode will be positive. Vectors that travel away from the electrode will be negative. And so here you have a positive ST segment. Okay. One way you can look at the seriousness or not of ST elevation is the frowny face is is serious. The smiley face is not. So here's a 68-year-old man who complained of chest pain. Okay, came to the emergency room complaining of chest pain, and here is his electrocardiogram. It has several premature beats, as you can see here. These are PVCs. This is a PAC, well, what's notable, don't look at the PACs or PVCs, but rather at the native beats. And what you can see is that what's prominent really is that the T waves are very tall and out of proportion to a T wave that one would expect in this lead with this size QRS here in V2, V3, and V4. Okay, these are hyperacute T waves, and the earliest sign of acute myocardial infarction. 45 minutes later, this is what his ECG looked like. And as you can see, this is fairly obvious. ST segments elevated in V2, V3, V4, V5, and really V6, and AVL, consistent with a large anterior infarction. Okay. Notice that this isn't much ST elevation, but it is elevated in leads 1 and AVL as well. And notice that. So the evolution of the ECG in patients who have had STEMI, the evolution of the ECG has evolved. Okay, but what we used to see is that following acute coronary occlusion, this is the normal, this is the hyperacute T wave. Okay, then the ST segment elevates, the Q waves develop in those leads, the ST segments come back down and T waves invert, and the T waves may recover. This takes place over hours, and this takes place over days. And we used to see this before the days of revascularization. Today, when patients are revascularized at this point, what you see after that are these T wave inversions, which are reperfusion T waves in the appropriate leads. And this shows the anatomic locations and the supplying coronary arteries for acute myocardial infarction. So in leads 2, 3, and AVF, these are this is an inferior infarction. Most likely the right coronary more than the left, possibly the left circumflex, but likely the right coronary artery. Anterior infarctions are seen in the chest leads V1 through V4, and the leads 1, AVL, and V5, V6 are called lateral due to either the left circumflex or a diagonal branch of the left anterior descending coronary artery. This would be the proximal portion of the left anterior descending coronary artery, and this might be a diagonal branch, 1 AVL and V5, V6. Okay, here's a 71-year-old man who complained of shortness of breath and almost passed out. Okay, and what you see is a very slow rhythm, right? Heart rate is 300, 150, 175, 60, 43 beats per minute. And what you can also see is that the P waves kind of march right through. There are no fixed PR intervals here. This one, as a matter of fact, is right on top of a QRS. Okay, so if it's right on top of a QRS, that implies AV dissociation. This is third degree AV block. We've talked about third degree AV block in the first talk, and it is due to a clot or obstruction of the right coronary artery, because there is ST segment elevation in leads 2, 3, and AVF. And because the ST segment is higher, ST segment elevation is higher in lead 3 than it is in lead 2, that is, 90+% the right coronary artery. Now, why? Let me see. The next. Yes. So here, he's back in sinus rhythm. Okay. After a stent was placed in his mid-right coronary artery. Okay. And the reason he developed heart block is because the right coronary artery in 90% of patients feeds the AV nodal artery. So heart block in inferior myocardial infarctions is due to ischemia of the AV node. Now, this is another situation. This is consistent with infero-posterior MIs. So here you see ST elevation in 2, 3, and AVF, but you see these very deep ST depressions in leads V1 through V3. Okay, and what that really represents can be seen if you took a mirror and put it up here, and what you'd see is ST elevation on the right side, and this shows where the vectors are going. So the posterior wall of the heart, the vectors are headed toward the back. So in V8 and V9 you'd see ST elevation, whereas in V1, 2, 3 you'd see ST depression, because the vector is traveling away from V1, 2, 3 and toward V8, V7, 8, 9. Now, ST elevation is not always due to acute myocardial infarction. This is a mnemonic for the causes of ST elevation, elevation. Electrolytes, left bundle branch block, early repolarization, left ventricular hypertrophy, arrhythmias, VTAC, for example, Takotsubo disease, which we don't have time to show. It may be due to infarction, and it may be due to coronary vasospasm. So let's look at some of these things. Here is left bundle branch block, wide QRS. If you look in V1, the QRS has a dominant S wave. That is, the main vector is traveling away from V1. V1 is located on the right side of the chest, so it's traveling away from V1, indicating left bundle branch block. What you also notice is that there's ST elevation N2 and V2, V3, and V4. Okay, is this a STEMI? Well, let's look here. Due to the depolarization abnormalities, there are secondary ST wave changes that represent repolarization abnormalities. And they go in the direction as follows. If the major abnormal deflection is upright, the ST segment and T wave are negative. If the major deflection is downward, the ST segment and T wave are elevated, as shown here. So those are just secondary changes. They don't represent anything new. The same would be true for left ventricular hypertrophy. Here's an example of left ventricular hypertrophy, and there's ST elevation, and you'll get a computer reading that says, myocardial infarction, maybe, of uncertain age. Well, it's certainly not new. Possibly there was an old one, but there's left ventricular hypertrophy here. And the ST segment changes are secondary, not primary. Now, here's a lady who developed chest pain at rest. And she had these really nasty looking ST elevations, in addition to ST depressions in V1, V2. So infero-posterior ischemia, anyway. Is this an acute myocardial infarction? Notice the time right here, 7:47 in the morning. Somebody gave her a nitroglycerin. And after nitroglycerin, 6 minutes later, the ST segment abnormalities are gone. You see that? Gone. And this represents coronary vasospasm. Here's these tracings show the development of vasospasm. You see here, beginning ST elevation, it gets worse, and then you have ventricular arrhythmias, which is one of the complications of this. And this is an angiogram during vasospasm, and then after nitroglycerin, showing relief of the vasospasm. So that is not acute injury or infarction. Here's a 36-year-old man with hypertension and hyperlipidemia who complained of chest pain for several hours, for 3 hours, which was worse while lying down. And what you see is diffuse ST elevations in leads 1, 2, not so much in 3, AVL, V2, V3, V4, V5, V6. They don't really follow one of the patterns that I've pointed out, consistent with acute myocardial infarction. Does anybody want to guess what this is? You want to put it in the chat? Try put your answer in the chat. Oh, somebody answered. Good for you, Kyle. You're right. This represents pericarditis, acute pericarditis with diffuse ST elevation, and notably PR depression in lead 2 and PR elevation in lead AVR. Okay, and that's pericarditis showing, and usually the ST segments are concave upward, that is smiley face. Okay, now here is a 47-year-old woman who complained of sharp pinching chest pain. This tracing was given to me by one of the nurse practitioners in our clinic. And it says, consider acute ST elevation MI by the computer. Okay, so let's have a look. there is ST elevation in inferior leads and the lateral leads. But this is definitely smiley face, is it not? What's she got? What do you think she has? She has the early repolarization abnormality. Okay, which may have a J point elevation, and it has this so-called this what I call a dipsy doodle at the end of the QRS, a J wave. It's hard to see on this particular tracing, but this illustrates what I'm talking about. So this is a normal early repolarization abnormality, which is a benign abnormality. And one of the ways that you can, well, there's the smiley face right there. Okay, it's a smiley face, not a frowny face. And one of the ways that you can tell what this is by having the patient do some sort of exercise. And what you'll see is that the ST elevation improves with exercise, with a faster rate. Now here's a tracing, which has very tall T waves. And the question is, are these hyperacute T waves of early ST elevation MI, or is this hyperkalemia? Want to give it a go? What do you, somebody put something in the chat, guys. Hyperkalemia. Well, not really. This shows the difference between the tall T waves of hyperkalemia and the hyperacute T waves of ischemia. The T waves of hyperkalemia are pointy, are really pointy, whereas these are not. They're broad, okay, and they're not. You're right. You can prick your finger on the hyperkalemic ones. And this shows the progression of STT abnormalities in hyperkalemia. And let's go back to here. And the other thing you can see is here are tall T waves, and here are ST depressions in the inferior leads. So these are hyperacute T waves in the anterior leads and ST depressions in the inferior leads. And we'll talk about that phenomenon when we come to ST depression. Here's a woman in her 40s who was found down, brought to the emergency room. What do you think are causing her tall T waves? A potassium of 8.1. She was treated with calcium gluconate, insulin, and bicarbonate, and her K came down to 6.5. And so here's her ECG with a potassium of 6.5. Looks a lot better, doesn't it? So that's hyperkalemia, and this is severe hyperkalemia. You get QRS broadening, these very tall T waves. You can't tell what the rhythm is. So bizarre QRS complexes, possible bradycardia, and what appear to be heart block. So this is severe hyperkalemia. Now, here's a 54-year-old woman with hypertension and alcohol abuse who presented to the emergency room after 3 episodes of syncope in 24 hours. This has sinus rhythm, and this is a ventricular couplet. But what's notable about this ECG? Someone put something in the chat. What do you notice? Someone thinks that there's a very narrow QRS, which is true. There is a very narrow QRS, but that's not it. Someone else thinks, yes, you're onto it. Very broad T waves and a long QT interval. You're right. You're right. The difference, so the normal QT interval is much less than half the RR interval. A long QT would be greater than half. And as you can see here, the QT goes from here to all the way over here. Rather striking prolonged QT interval. And her syncope turned out to be or let's put it this way. The risk from prolonged QT is that of polymorphic VT or torsade de pointe, torsion of the points. And this was her tracings, which showed polymorphic VT, which deteriorated to ventricular fibrillation. She was successfully resuscitated, and it turned out that her potassium was 1.9, which was the source of the problem. This is an example of typical torsade de pointe. The points are up. It's a wide complex tachycardia, irregular tachycardia. The points are up, then down, then up in the same lead. Twisting of the points. There are a number of risk factors for drug-induced torsade, which is why I emphasize this, because there are a number of drugs which can lead to it. I'll get to that on the next slide. But the risk factors are QTC of greater than 500 milliseconds, then the three hypos: hypokalemia, hypomagnesemia, hypocalcemia, the use of QT prolonging drugs, the concurrent use of more than one QT prolonging drug. So these are the things that people should be aware of and on the lookout for. And this is a very partial list of drugs that pose a risk of torsade de pointe, right? Including antiarrhythmic drugs, antibiotics. I should put in azithromycin here because it belongs. Antidepressants, and then some others, including methadone, arsenic, arsenic poisoning, and hydroxychloroquine. You remember that in the early days of COVID, and sumatriptan. That's where heavy metal was.
More in my plans.
And these are some clinical scenarios for torsade de pointe risk. Concomitant therapy with another QT prolonging drug, a potassium wasting diuretic, one of the thiazide diuretics, for example, with another QT prolonging drug, renal failure, in a similar kind of situation. Now, what are some common causes of ST segment depression? You can have ischemia, you can have what's called strain, you can have digitalis effect, hypokalemia or hypomagnesemia, but mostly hypokalemia, and then some rate-related changes or some combination. And in this case, With subendocardial ischemia, the vector is traveling away from the electrode, giving ST depression and T wave inversion. Now, this is common and important to recognize because these are secondary changes, not primary changes, reciprocal ST changes. And what this means is that if there is an acute ST elevation, MI, in one territory, then there will be reciprocal ST depression in the opposite territory. As for example, here is, if you look over here, here is acute inferior ST elevations. Okay, ST elevations in 2, 3, and F, and reciprocal ST depression in 1 and AVL. This is anterior. There's ST elevation in 1 and AVL, and ST depression in 2, 3, and AVF. And so you recall the ECG I showed with the very tall T waves. This one. So this is anterior, right? This is going to be an anterior infarction, and there's inferior reciprocal change. All right. Now, we come to a non-ST elevation MI, NSTEMI. A lot of things are called NSTEMIs that really aren't. And sometimes NSTEMIs are due to non-obstructive disease, but sometimes they're due to obstructive disease and you just don't realize it. So those are things that need to be considered. So here is some ST depression in the precordial leads, which is thought to be due to an NSTEMI. And here's T wave inversion that likewise represents an NSTEMI. Here's a man that was on the wards at Beth Israel not long ago. A 77-year-old man with known hypertension who had a carotid endarterectomy, and in the recovery room he developed extreme hypertension and a hypertensive crisis because he had chest pain. Right? Extreme hypertension is not a crisis unless you have some symptom that's related to the extreme hypertension. Cerebral edema, cerebral bleeding, chest pain, heart failure, that sort of thing. So this is what happened to him. He had extreme hypertension and then developed chest pain and had this ECG, which has ST depressions in the inferior and lateral leads, as you can see here. Okay, and compare that to his preoperative ECG. So here's the pre-op tracing, and the pre-op tracing. Oops, sorry about that. All right, the pre-op tracing shows changes which are probably consistent, which are consistent with left ventricular hypertrophy, and that ST elevation I mentioned, and here's V2, V1, and V2, right? So this is just LVH, and these are also secondary changes, not primary changes. But this is what he presented with chest pain, and they're much more prominent, as you can see, particularly ST depressions and lead in V5 and V6. Okay, so his troponin rose and fell, excuse me, and he went to the cath lab, and the coronary angiography showed non-obstructive coronary disease. So he had this, and all of his subsequent tracings look like this. There are at least a half a dozen of them, and they all look just like that. So he had ST depressions, which did not evolve and did not develop Q waves. And this is consistent with an NSTEMI that is not due to obstructive coronary disease. Now, here's a woman with hypertension and diabetes who complained of chest pain. And she's got some rather, what's striking about this is the rather prominent ST depressions. 1, 2, 3, AVF, V, 2, 3, 4, 5, and 6. Widespread ST depressions. Is this an NSTEMI? Well, look at AVR. There's ST elevation in AVR. What does that mean? Beware ST elevation in lead AVR, because it indicates subendocardial ischemia due to an oxygen supply-demand mismatch, often due to severe left main coronary artery stenosis. Not occlusion, because occlusion of the left main usually, people who occlude their left mains usually die pre-hospital. But it's severe stenosis of the left main, possibly of the LAD, or severe triple vessel disease. So they can have a severe disease of the left circumflex and a clot in the LAD, which would give you sort of a left main equivalent, what I would call a left main equivalent with severe three-vessel disease. ST elevation in lead AVR is a useful predictor of a poor outcome and of the need for CABG surgery. And therefore, as these people enter the hospital, you should withhold clopidogrel in case in case the patient needs bypass surgery for severely stenosed left main coronary artery. On the other hand, the absence of ST elevation in lead AVR essentially excludes severe left main coronary artery stenosis. Now, you can have ST segment changes during exercise, and these come from stress tests. So here's the normal response to stress, the ECG and lead V5, a normal response to stress. If there's a rapid upsloping that disappears in the first minute, that's normal as well. There may be minor depression. Again, this is probably going to turn out to be not significant and disappear in under a minute. But as slow upsloping or horizontal ST segments or downsloping ST segments are an indication of ischemia. Also, ST elevation in a non-Q wave lead or an AVR, right? So, ST elevation in AVR on a stress test should raise the possibility that you're dealing with severe three-vessel disease. Okay. And then turning to another condition, hypokalemia. The changes of hypokalemia are ST and T wave abnormalities, going from this would be more normal, and then as the potassium rises, you get ST T wave flattening, followed by ST depression. And T wave, hard to know whether this is inversion, but you can see these ST-T abnormalities and prolonged QT. And this is an example of hypokalemia with a prolonged QT here. QT goes from here to all the way over here. Okay, so this person would be at risk for torsade. Now, here's a 65-year-old man with atrial fibrillation who takes digoxin. And digoxin can cause these scooped-like ST segment depressions, which have been called similar to Salvador Dali's mustache. Okay, in this case, you have a slow, regular rhythm, which looks like it's junctional. All right, he has AFib, so it's very slow AFib with perfectly regular rhythm. Looks like it's junctional, which indicates that there is heart block and a junctional rhythm. This is a digitoxic rhythm. A patient with atrial fibrillation on digoxin, whose rate is this slow, is digitoxic. Although I don't know the any more data on this particular person. Okay, so there's Salvador Dali, and then I'm going to skip ahead and show you one last condition. Okay, here's a 72-year-old woman with paroxysmal AFib who got a pacemaker for symptomatic conversion pauses. Okay, so here she is being paced. Okay, the pacemaker is in the right ventricle. The way I know that is because the paced beats have a left bundle branch block appearance. Okay, so here she's paced. Then a week later, they turn off the pacemaker. Well, here you can see some paced beats, some paced. Was this a dual chamber pacemaker? It doesn't look like it. Okay, and look what you see. You see some sinus beats and pauses, but you see T-wave inversions in the inferolateral leads, rather prominent T-wave inversions. Is this ischemia? No, this is a condition called cardiac memory. So here are two examples to show you the difference between ischemic T-wave inversions and cardiac memory. So this is cardiac memory here, and this is ischemia. And the way you can tell the difference is, right, so there's inferior lateral T-wave inversion, and anterolateral here, inferolateral here, but with with ischemia, you have STT abnormalities in lead AVL, whereas with cardiac memory, AVL is normal. So that's the way you can tell the difference. And cardiac memory is a benign condition, not to be confused with ischemia. Okay, in which case, I'll give you my parting shot, which is this. And I thank you very much, and I'll be glad to take questions. So, do you have questions? If you do, you can either put them in the chat. We have a question. Oh, we have a smiley face. Thank you very much, Anadi.
I'm just going to throw a couple things in the chat, Dr. Schulman.
Okay, are there questions?
I don't see any yet, but it's just some thank yous, a smiley face. I just want to remind everybody about the CME survey and that it'll appear in the tab when you close out of this webinar. We'd really appreciate you taking the few minutes to complete this. Not only does it give you the CME credit, but also helps us plan the best session for you. Okay, I do have a question. It's in the chat, Dr. Schulman.
Recommend nitroglycerin immediately after noting ST elevation in AVR as they may die pre-hospital. I see your point. In other words, your question has to do with suppose you see these changes in the office. What should you do? Well, it would depend on whether the patient has acute chest pain or not, because the patient could not have acute chest pain and could have ST elevation in AVR, which would indicate severe three-vessel coronary disease. But if the patient is having acute chest pain, again, it would depend on whether you you think he's having acute infarction and what his blood pressure is. If his blood pressure is low, I wouldn't give him nitroglycerin or give that person nitroglycerin. If their blood pressure is high, I think nitroglycerin would be indicated. Is it possible to get a full list of the QT prolonging drugs? Yes, it certainly is. You can Google QT prolongation. There are websites that have the full list. As I said, it's maybe a page and a half long. Exact reminder. Okay. Any other questions?
I don't see any right now. I see a couple more thank yous.
Okay.
I do have one over here in the Q&A. How likely is there still ischemia if there is no EKG changes at all? Still should send to ER from clinic to TRAP.
Good question. Right. So patient is having chest pain and you think it's ischemic. Is that the question? But the ECG during chest pain is normal. I think you have to go on your clinical impression at that point. It would depend on what you think about the character of the chest pain. I can show you another slide that illustrates the character of the chest pain. If you have an ECG that's normal, right, and not with subtle ST elevations, but normal, then it's unlikely that the chest pain is ischemic, and the patient needs to go to the hospital. On the other hand, if you have a patient who has come in and complained of chest pain or transient chest pain, they get chest pain when they walk up a hill or so forth, and their ECG is normal at the time of your visit, but they're not having chest pain at the time, that doesn't help you. That doesn't help you. So hold on a minute, and I will. Come on. Okay. I want to close that. Okay. Okay. And now, give me a moment. Here. Screen. Show you a couple of these slides. Okay. Okay. So one of the things you have to do when a patient presents with chest pain is make sure they don't have something that's life-threatening. And then this is what I wanted to show you. An indication, an index of suspicion that the chest pain or symptom is indeed ischemic. The more likely it is, the more it's described as central or pressure or squeezing or gripping or heaviness or tightness, the likelihood is high. At the other end of the spectrum, tearing, ripping, sharp, fleeting, shifting, pleuritic, positional, stabbing. I would put stabbing over here someplace. Okay. Burning can be an issue because there are any number of people who have thought that they had esophageal reflux that turn out to have coronary ischemia. So I'm not sure I'd put that here. I'd put that more over here somewhere. But I think you get the point. Okay. Questions? The caveat is how people define pain. That's right. And cardiac ischemic pain is often not described as pain. I would call it a discomfort. Yeah, I can't resist, so I'll show you one more slide. The ACC/AHA came out with a chest pain guideline 3 years ago. The old descriptions of chest pain were typical angina, atypical angina, or non-anginal chest pain. And people have been using atypical chest pain to describe almost everything. Everything that's not this, but anywhere from there to here. And the new guidelines suggested that that you shouldn't use that because it doesn't help you to determine the cause, and it may be misinterpreted. Atypical pain could be close to concerning for coronary artery disease. On the other hand, it could be sharp stabbing on the left lateral chest, pleuritic. It's it's atypical, but that doesn't help you. So what they suggest, the terminology they suggest we use is consider the pain cardiac, non-cardiac, definitely not cardiac, or possibly or probably cardiac. And that helps you to try to decide how to work up that chest pain, that symptom. Right? Is that gonna wrap it up, Jennifer?
I think so. I don't see any other questions. So
Okay.
Thank you so much, Dr. Schulman. It was a great presentation as always.
Okay, thank you. If Lisa Jones is on, can she stay on? I have a couple of questions.
I don't see Lisa Jones. I do see another Lisa though.
No.
Okay.
There's Lisa Jones is the one I want to talk to.
Okay. Yeah, I don't see her on right now.
Okay, in that case, I'll give her a call. Well,
Okay. All right. Hope everyone has a great rest of your day. Thank you for coming. Bye, Dr. Schulman. Thank you.
okay, bye-bye.